Hello, everyone. I'm Dr. Karthik Munichoodappa from Bangalore, Frank Karthik Hospital. I'm a consultant physician and diabetologist. And today I have this opportunity to speak to you about the latest update in hypertension. Now, to just give you a background about hypertension, as per the World Health Organization, nearly 63% of the total deaths in India are due to non-communicable diseases, and of which 27% are attributed to cardiovascular disease, which affects 45% people in the age group 40 to 69. Now, raised blood pressure is among the most important risk factors for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness among the population about hypertension and also lack of appropriate care through the primary care physicians. And there's always a poor follow-up once they even seek medical help. Now, in India, the prevalence has also gone up over the last 30 years to 38% in men and 32% in women, from what was 29% in men and 28% in women, respectively. So these are all the data from the WHO. And despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, were unaware of the condition they had. Now, additionally, over 62% of the men and more than 53% of the women living with hypertension did not seek treatment or get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. Now, the International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings, optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The AHA and the ACC has released a scientific statement in 2021 offering a new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk and among low risk adults where the 10-year CVD risk is less than 10% with stage 1 hypertension, which is again blood pressure between 130 and 139 systolic and 80 to 89 diastolic millimeter per mercury. And management starts with non-pharmacological therapy. And if blood pressure remains uncontrolled at 3 to 6 months, we should consider starting therapy for them, that is medication. Now, ARDS is potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19, what we saw in the first and the second wave. A recent study which appears in the Journal of the American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Now, lowering systolic blood pressure targets down to 110 to less than 130 millimeter per mercury range substantially reduced cardiovascular adverse events in the STEP randomized trial, affirming the sprint findings for an older Chinese population. Among some 8,500 patients with ages between 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from threshold of 130 to 150 of millimeter of mercury. Now, with regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only depend on office BP measurements, but also out of office measurements such as ambulatory blood pressure monitoring, which is now very commonly used in our practice to even diagnose somebody to have hypertension. or you can also offer them home blood pressure monitoring, and also 24 and nighttime BP measurements were associated with greater risk of mortality and composite of cardiovascular outcomes. Thus, they may be considered as the most relevant measurements for the estimate of cardiovascular risk. For every 20 millimeter of systolic and 10 millimeter of diastolic increment of blood pressure measurement at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence to treatment, the importance of combination treatment is particularly highlighted to improve adherence, therapy, and blood pressure control. Therefore, the 2018 European guidelines recommend, especially in the context of lower blood pressure targets, to start antihypertensive therapy with an initial dual fixed combination, such as the ACE inhibitor or ARB with calcium channel blockers or a diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. And the reason is the detection of a known carcinogen, namely the NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. The NDMA has been classified by the WHO and the International Agency for Research on Cancer to be carcinogenic in humans. If 100,000 patients would have received the NDMA-contained valsartan from the Zhejiang, which is the manufacturing site where the highest levels of the contaminants were found, every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 100,000 patients if they had been taken the highest daily dose over 4 years. So valsartan recall accompanied by a significant increase in the rate of emergency department visits of more than 6%. Now coming to the HYGEA study, which represents the largest study that tested nighttime antihypertensive treatment. And in this trial, chronotherapy was associated with significant reduction in endpoints, which includes death. The HYGEA chronotherapy trial tested whether the nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. The largest study included a total of 19,000 hypertensive patients during an average follow-up of 6.5 years, with 1,750 participants experienced the primary cardiovascular outcome. An ambulatory blood pressure measurement was performed for 48 hours to collect data on how BP differed during sleep. The relative risk reduction for cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatment. So these are some of the latest updates in the field of hypertension, and I hope it's of use to you in your daily practice. Thank you very much.